Hello, and welcome to the Liver Cancer webinar. This is the first installment of a three-part webinar series we'll host this year on liver cancer. This is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Liver Health Foundation is a patient advocacy nonprofit organization representing millions of liver patients in California and beyond. Our mission is to provide updated and accurate information on liver health and promote prevention of liver disease, advocate for equity in access to healthcare, and host patient and physician centers, educational and community programs and events. Tonight's webinar is about liver cancer. As you may know, there are more than 100 different liver diseases caused by viruses, genetics, autoimmune disease, excessive alcohol use, poor diet, obesity, reaction to medication, street drugs, and toxic chemicals. Liver cancer was once mostly seen in older adults and patients with hepatitis, but it is now seen in younger patients and those without hepatitis. Today's liver cancer stands apart from all other liver diseases since it is one of the few cancers that is on the rise in the US due to all the elements that I mentioned before. While many researchers, physicians, and pharmaceutical companies are working to develop better and more reliable treatments to diagnose, prevent, and treat liver cancer, there are still many liver patients who die of liver cancer while waiting for liver transplantation. I have read that it's estimated every year over 30,000 people die of liver cancer. In tonight's program, we will hear from some of the best liver specialists about this disease, as well as the advances that have been made in medical research. Now I have to put in my disclaimer, so please remember information given by our experts is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, and treatments. So please listen to what you hear, get this information, and discuss it with your own doctor. So I want to thank our sponsor, Exelixis, and I will now invite Exelixis representative, Mr. David Schmall, to say a few words about Exelixis and its work in the liver cancer space. David?
Yes, thank you very much for the warm welcome, Farah. And hello, good evening, everybody. I'm with Exelixis, as Farah has mentioned, and would like to just introduce Exelixis as a company. We're based up in Alameda, California, so here on the West Coast. And we were actually formed in 1994. Our focus is on the discovery and development of cancer medicines for hard-to-treat cancers. We're dedicated to scientific excellence, as well as providing support for patients in our community. We're very appreciative to have this opportunity to support the Liver Health Foundation. It's just a great chance for patients to get legitimate medical information delivered by great physicians who are experts in their field. So it's a great opportunity for everyone. Thanks again, Farah, for having me this evening. Dr. Ahern and Dr. Singh, just really looking forward to these presentations and hope everyone in attendance benefits and gets something out of this. So thanks again.
Thank you, David, and thank you, Exelixis. We really appreciate the support we get of our, from our pharmaceutical companies. Now it is my pleasure to introduce Dr. Erin Ahern, who has generously accepted to be the presenter and the host of our tonight's roundtable discussion. Erin Ahern, MD, PhD, is the Assistant Professor of Surgery and Surgical Director of the Liver Transplant Program at Keck Medical Center of USC. Dr. Ahern has an active clinical practice as a liver, kidney, and pancreas transplant surgeon, including living donor liver transplant. His clinical research interests include liver transplant, organ allocation, expanding the use of living donor in liver transplant, bloodless liver transplant for those patients who are unwilling to receive blood products, and studying the economic impact of liver donation. He also serves as the Region 5 representative on the United Network for Organ Sharing's Liver and Intestine Committee. He has an extensive background in transplant immunology, having previously studied the natural tolerance of liver allografts in transgenic mouse models. Dr. Ahern is an active member of ASTS, serving on the ASTS Regulatory and Legislation Committee, and previously has received the ASTS Roche Laboratory Scientist Scholarship and the American Foundation for Donation and Transplantation Careers in Transplantation Award. Dr. Ahern is a member of the Liver Health Foundation's Medical Advisory Council. I also have to mention that in 2023, Liver Health Foundation awarded USC Liver Transplant the Excellence in Healthcare Award, as well as two doctors that we have worked with for many years, and everybody knows them, Dr. Genick and Dr. Kohli. So we were honored and proud to be acknowledging the wonderful work that USC does and the doctors like Dr. Ahern are performing. Dr. Ahern, I believe this is the first time you're joining us as a presenter of the webinar. I want to extend a warm welcome to you. Thank you for your support and participation, and we are now ready for your presentation.
Well, Farah, thank you so much for that warm welcome. I'm going to share my screen. I'll be talking about liver cancer, things to know for patients. My goal of this was to speak very plainly and to use normal English to describe things as much as possible, but also connect that English to the jargon that you'll hear in the medical community, so that when your doctors start talking about things, you'll know the words that they're going to use to understand what they're talking about. It is very common for me to slip back and forth between English and doctor. And if there's any questions or anything that isn't clear, feel free to ask, and I'll do my best to explain it. But I really wanted to start with the basics of what is cancer and why does it occur. And essentially, cancer is a group of cells that are growing when they're not supposed to. And your body has multiple molecular systems to control when cells are supposed to grow and when they're supposed to stop. And cancer happens when those brakes start to fail. There's multiple fail-safes in your system that have to go bad in order for cancer to develop. But if you have multiple errors in a row, cells can start to grow out of control. And they can cause problems in two ways. They can either grow locally and cause damage, or they can spread throughout the body, which is what doctors refer to as metastasis. In order to get metastasis, another series of breaks have to fail, and those cells have to gain the ability to sort of spread outside from their original location. But the problem is the faster cells start growing, the more errors accumulate, and the more likely these negative things are about to happen. So one of the things about cancer is it tends to occur in places in your body where cells have to regrow. And what we'll show is there's an intimate connection between liver disease and liver cancer, because as the liver is getting injured, the liver cells start growing back, and that proliferation of cells is what makes us prone to have cancer in the liver. So I'm going to discuss the two main topics today: hepatocellular carcinoma, which is cancer of the liver cells, and something called intrahepatic cholangiocarcinoma, which is cancer of the cells in the bile ducts that exist inside your liver and can also form cancers. The word intrahepatic just means inside your liver, because you can get bile duct cancer either inside the liver or out of the liver, and today we'll focus on just cancers that are inside the liver. But those aren't the only masses or tumors that you might see inside the liver. The liver is also a place that can the downstream end of metastasis. So things like colon cancer start in the colon but spread to the liver, and so we might see cancers in the liver related to other. We might see cancer in the liver that's related to other types of cancer. Obviously, that's not the subject of this talk, but if you get diagnosed with a mass in your liver, you need to know that that's one of the things that potentially could be. And there are also masses in the liver that are not cancer. And it's really important for patients to know that these exist because most of the time cancers show up on some sort of imaging study, and you may hear from your doctor that you have a mass in your liver. And I want to let everybody know that this isn't necessarily a reason to panic because there are lots of things inside your liver that can look like a mass that actually are benign and aren't going to hurt you in the long run. There are three types that are pretty common in the liver. One's called hepatic adenomas. It's not a cancer, but it can turn into cancer. And it's one of the things that, that your doctor may diagnose you with. But there are also these things called focal nodular hyperplasia, which is just an abnormal growth of liver tissue, but it doesn't have any cancerous potential. And then there's a third thing called hemangiomas, which are just a really disorganized group of blood vessels. So it looks like a cancer, but in reality, it's just a mass of blood vessels that doesn't have any liver tissue associated with it. And again, these are not cancer. They can't turn into cancer. And most of the time when we find them in the liver, our job is just to tell our patients, it's okay, we don't need to worry about it. Now, no patient has ever walked into the doctor's office and said, "Doc, I have pain from the mass in my liver." It's just not the way our bodies work. We don't feel things inside of our liver. And so therefore, masses can grow in your liver with you being completely unaware of it. And most of our patients don't have symptoms, which is one of the challenges in that these life-threatening conditions can develop and our patients may have no idea. But most of the time, we find these cancers or masses doing some sort of imaging test, either because we're intentionally looking for cancer in some of our patients that are high risk, or because they got a CT scan, an MRI, or an ultrasound for some other reason. And at the same time, we found this mass, and now we have to figure out what it is and what to do about it. When we're trying to work up liver cancer, we can find it in lots of different ways. All of those studies I just said, CT scans, MRIs, and ultrasounds, can find and identify a mass in your liver. But to know what it is, we really need a special type of CT scan. And that's called a 4-phase CT scan because they look at the blood flow inside the liver at 4 different points. And we can tell, because cancer has a slightly different blood flow pattern than the liver parenchyma, you can tell what's cancer and what's not. So oftentimes patients will come in with a CT scan that says we're worried we have a cancer. And the first thing I'm going to say is you need another CT scan. But that's the reason. It's about the type of the CT scan and the way we do the CT scan that helps us get the details we need to figure out, 1, what is it cancer? 2, what type of cancer is it? And 3, what are our options in terms of treating it? So this is a picture of a CT scan showing your body basically cut across yourself. So if we cut you in half, you would see that this is your liver, this is your spleen, and this is the big artery that goes into your liver. And this is the same picture, but taken a few seconds later, now we can see the big vein that goes into your liver, and you can see that the colors are a little bit different on these 2 slides. This is a cancer. This little round circle that looks brighter on this picture and looks darker on this picture is a liver cancer. And that characteristic of bright at one point and dark during the other is how we identify these things as cancer. And when we see this, we know this is something we have to be really concerned about. But how likely that is to be cancer is completely dependent on you and your medical history. Liver cancer tends to develop in the setting of cirrhosis. And that's, like I talked about at the beginning of the thing, it's because you have chronic injury of your liver that leads to cirrhosis. The cells are continuously growing back. And as those cells grow back, that leads to cells that are growing. Cells that are growing can get an error. Errors can occur, errors can accumulate, and then you may end up with a cancer. So things that cause damage in the liver and regrowing cause cancer. And for the liver, that really is any cause of cirrhosis. Different causes of cirrhosis have different rates of developing liver cancer, but any cause of cirrhosis is a risk factor for developing liver cancer. Also, viruses that affect the liver, like hepatitis B, can cause cancer even in the setting, even if you haven't developed cirrhosis yet. So hepatitis B is a second and independent risk factor to cirrhosis for you getting liver cancer. On the contrary, bile duct cancers tend to be related more to the patient's age. With the older you get, the higher you risk, or special conditions that cause damage to the bile ducts. There's some autoimmune disease that can cause both cirrhosis and damage to the bile ducts, and some of those patients are at higher risk of developing bile duct cancer. For most patients who are healthy and have no history of liver disease, if you are found to have a mass inside your liver, that mass is much more likely to be benign because you're much lower risk for developing a liver cancer. So now I'll focus specifically on hepatocellular carcinoma, which again is the cancer that comes from liver cells. And the risk factors, like we just talked about, it's cirrhosis, hepatitis B. Interestingly, males more commonly get cirrhosis or more commonly get HCC than women. In the US, people of color are more likely to get HCC than non-Hispanic whites. Obesity is a risk factor for developing HCC, and cigarette smoking increases your risk factor for HCC. Also, alcohol use increases your risk, mostly in the development of cirrhosis. So we as doctors recognize the patients that are highest risk for liver cancer and have developed screening protocols to look for liver cancer that develops. And that's all of our patients who've developed cirrhosis and any of our patients who have hepatitis B and are high risk. So that's anyone over the age of 40, Asians and Black men who are not from Africa with hepatitis B, Asian women over the age of 50, anybody with a family history of HCC, and Black Africans over the age of 20. For our patients with cirrhosis, it can be patients who have relatively mild cirrhosis or the patients with the most severe versions of cirrhosis who really need a liver transplant to treat their cirrhosis, but we have to watch out for cancer developing while they're waiting for a liver transplant. So we screen patients basically every 6 months if they meet these criteria, and we usually alternate ultrasounds with those CT scans to try to pick up masses that may have developed over that 6-month period. Once you're identified with having a mass in your liver, the next question is how do we make the diagnosis and prove that it really is indeed liver cancer? Now, as I showed you, liver cancers have very distinct characteristics on either an MRI or a CT scan that makes them pretty unique. If you have a mass in your liver that is classic on these imaging, and you have cirrhosis or other risk factors like hepatitis B for cancer, and the lesion is larger than 2 centimeters, that's all the information your doctor needs to know this is liver cancer, and we will treat it as a liver cancer if all of those criteria are met. That makes it different from most of the other cancers that we diagnose, because almost every other cancer in the body, we want to get a piece of tissue of the tumor to know exactly what it is before we start treatment. But it's only because this disease is so characteristic that it's not necessary to get a liver biopsy if you meet all the criteria based on imaging. Now, smaller lesions can look like cancer, but sometimes they're just nodules in the liver, particularly in patients that have a pretty severe versions of cirrhosis. So if you have a small lesion, your doctor may recommend that we just watch it, and only if it's growing or it gets greater than 2 centimeters would we then act on it and treat it like it's cancer. And there are often other times where we'll see a mass in the liver, but it doesn't meet all these criteria. Either it isn't perfect on the imaging, or you aren't a patient that has cirrhosis. And in those situations, we're more likely to recommend a biopsy so we can get an actual diagnosis of the cancer and know how to treat it. Once we make the diagnosis, what are our treatment options? And for liver cancer, your best chance of cure is still to cut all of the cancer out. Now, that's only true if the liver cancer is contained within the liver and hasn't spread to other places in the body. And there are limitations on our ability to successfully cut cancer out. There are 2 options for basically doing a surgical resection of a cancer. And one is to cut out the part of the liver that has the cancer in it, and the other would be to do a transplant. There are times when neither of these options is available, and we are looking for options to control the cancer, but these mechanisms of control may not be as effective in generating a long-term cure. And we call these local regional therapies because we're treating the cancer at the site, but because we're not completely taking it out, the cancers have a low rate of coming back. And there are different options to locally treat a cancer. We can basically burn it. There's something called microwave ablation, where they'll stick a needle inside the cancer and burn the area around that needle probe. And that's how we burn a cancer inside the liver. There's also something called radiofrequency ablation, which is the same concept. It just uses heat instead of microwave. And then there are further treatments where we treat the cancer from the inside. So we can go inside your arteries by poking you in the leg and getting inside your arteries. And we can actually follow the artery all the way into the liver and find the cancers inside the liver based on the artery blood flow that's going to that cancer. Liver cancer steals blood flow from the artery, so it's actually easy to find with that mechanism because it actually takes extra blood vessels from the artery for it to grow. It also makes it vulnerable to treatment that we can give from the inside of the artery. So there's something called a TACE treatment, which basically means trans-artery, in other words, through your artery, chemotherapy, embolization. So we inject cancer drugs into the tumor, and then we inject a second molecule that will actually block up the arteries, and therefore kill the blood supply that's going to that tumor and can help treat the tumor. We can also treat tumors with radiation. Use the same pattern. You go in through the artery, but instead of injecting a chemotherapeutic agent, you inject very tiny beads that are radioactive, and that emanates radiotherapy that will kill the cancer. And that's something called Y90 treatment. Which of these treatments your doctor would select completely depends on where the cancer is, how big it is, how close it is to other blood vessels and other structures in your body. So it's not that one of these options is better than the other. They all are pretty effective. It's that the doctors have to choose which is the right one given the circumstances of your particular cancer. And the final option is external beam radiation, where they shoot radiation to your body and focus it by shooting multiple beams to basically use computer targeting to focus exactly where that cancer is. Now, all of those treatments are good for the cancer that's contained inside your liver, but it won't control a liver cancer once it's spread outside the liver. So in situations where the cancer has spread outside the liver, in that case, you need systemic therapy that will treat the entire body and treat any cancer cells that are traveling through the body. And this used to be very specific therapy, something called sorafenib, which is a targeted molecule that targets liver cancer, which was our best treatment, but it never really provided a good chance of cure for our patients. Nowadays, we're actually targeting cancer with immunotherapy. So we actually have things that stimulate the immune system, and the immune system will then go and kill the liver tumor. And we're having very encouraging results with systemic therapy with immunotherapy. So the game has changed in the last 2 years, and that the treatments for even liver cancer that has spread has really evolved, and our prognoses are much better, our outlooks are much better than they used to be. I am a liver transplant surgeon, but I also do surgical resections for liver transplant. And so this is really my bread and butter. The question of whether you should try to cut a tumor out versus do a transplant where we're going to take the whole liver out and have to put a new liver in its place. Of those two options, resection is certainly the simpler medical treatment. We're just cutting part of your liver out. And you don't need to be on immunosuppressive therapy to protect the liver for the rest of your life. And so the simply cutting a tumor out is the simpler answer. But there are lots of limitations to our ability to be able to do that. The liver has two sources of blood going into the liver, one source of blood going out of the liver, and this tube called your bile duct, which connects your liver and your intestines. All functional liver has to have all four of those things in order to work well. When we're trying to figure out if we can cut part of your liver out, we have to consider what are we going to take out, and can we get the cancer out with what we take out? But we also have to consider what we're going to leave behind. And any liver tissue that we leave behind has to have all four of those connections in order for it to continue to work. So when we decide how to cut pieces of liver out, we're really looking at what we're leaving behind to make sure we're going to leave you with a liver that works the way that it's supposed to. So in order to be able to do surgery for liver cancer, it has to be contained to one side of the liver to give us an option to take it out. What we're going to leave behind has to be healthy enough that it's going to recover and grow to full-size liver. And it has to have all the connections that it's needed. The problem with cirrhosis is once you've developed a liver cancer, it's a sign that your whole liver is prone to developing cancer. And so many of our patients present not with one liver cancer, but with multiple liver cancers throughout the liver. And they have cirrhosis. Their liver is not healthy and not going to tolerate being cut up the way that a normal healthy liver would. So oftentimes we actually prefer to recommend transplant because it not only will treat one tumor, but it will treat all the tumors that are spread in the liver, whether we've found them yet or not. It will also treat your cirrhosis. So if you have cirrhosis and all the risks of having cirrhosis, a liver transplant will cure you and prevent you from getting new cancers and worsening of your cirrhosis. But we can only do transplant if the cancer is, again, contained completely inside the liver. And the outcomes are only good if the cancer is small enough that we're confident it won't spread outside the liver after transplant. Very big tumors or lots of tumors or tumors that have invaded the vessels inside the liver have much too higher rate of coming back for us to recommend transplant, because getting a transplant and having the cancer recur or come back limits your cancer treatment options. So those are the different things your doctor is going to be thinking about when they're trying to figure out what the best way to treat your liver cancer is. But for most of our patients with cirrhosis and most of our patients that have multiple tumors, transplant is going to be our top recommendation if you're a candidate for it. If you're not going directly to surgery or transplant, there's definitely a benefit to using those local regional treatments I talked to you about to slow the cancer down. And sometimes we use those in combination. So we'll use the local regional treatments to shrink the cancer or control the cancer while we're waiting to get you to transplant. If the cancer spreads outside the liver, then surgery is not helpful because it won't completely cure your disease and it'll slow down your ability to get the treatments that can control your cancer. Same thing is true with transplant. Transplant, because we have to give you the immunosuppression, we can actually make cancer outside the liver worse. And so we don't want to do a transplant if the cancer is spread outside the liver, or it's grown so big or so spread out that we think it's very likely to already be outside the liver, even if we haven't found it yet. So in those situations, we refer you to our oncology partners for systemic therapy, which treats the entire body and treats cancer cells throughout the entire body. So that's my spiel on liver cancer. I'll switch over quickly to talking about bile duct cancer, which can also occur inside the liver. Bile duct cancer is known as intrahepatic cholangiocarcinoma. That just means bile duct cancer inside the liver. Bile duct cancer is a much more aggressive tumor in terms of its tendency to spread outside of the liver. So it is more likely to metastasize than liver cancer. And sometimes it is spread microscopically well before we see it on CT scan. So it may look like it's just a mass inside the liver, but it may have already spread. Your best chance for cure for bile duct cancer has traditionally been surgery to cut it all out. And if we can do a successful surgery where we can excise all of the cancer, it's your best chance of cure. But even if you get a surgical resection, your oncologist is likely to recommend chemotherapy in addition to the surgery because the risk of it having already spread outside the liver, and we want to treat any cells that may have spread because it gives you your best chance of cure. Traditionally, transplant has not been an option for patients that have had what we call cholangiocarcinoma in the liver, because the risk of spreading afterwards was so high, the outcomes weren't good. But there's more and more data growing that's showing that in a very select group of patient population, liver transplant may be an appropriate option for people who can't get a simple surgery to cut the tumor out, and under very specific limitations. But even the UNOS board has recognized now that this is a potentially viable treatment option and is giving patients a pathway to get a transplanted organ with certain contained types of cholangiocarcinoma. And if the cancer is already spread, then the treatment for bile duct cancer is chemotherapy, and we will recommend systemic chemotherapy to try to slow down and treat the disease. And that's the end of my talk, so I'll hand it back over to open up the roundtable discussion.
Sorry, I was muted, so I'm here. I haven't left. This was a wonderfully comprehensive review of liver cancer. Thank you so much. I also loved when you talked about the English versus doctor speech, because we all get confused when our doctors talk to us in big terms that as a normal, not gone to medical school, we really don't have any idea what they're talking about. So this was wonderful. And I have a couple of questions. We'll come back to it when we start our roundtable discussion. So in this part, as some of you know, that we will have the doctors discuss the issue as well as answer to your questions. I had received some questions which I have forwarded to Dr. Ahern, Dr. Singh, and Dr. Malmstrom that they will review and respond to as the situation come available. So now I want to introduce the other expert members of our panel. So I'm honored to introduce Dr. Lale Malmstrom. Dr. Malmstrom, MD, MSCI, is Associate Professor of Surgery and Immuno-Oncology. She is the Chief of Division of Surgical Oncology, co-lead of Gastrointestinal Disease Team at City of Hope National Medical Center. Dr. Malmstrom is a talented surgeon and award-winning instructor and researcher. She has been educated at Johns Hopkins University. She received her medical degree at Cornell Medical College in New York City, continuing her training at Northwestern Memorial Hospital in Chicago and New York's Memorial Sloan Kettering Cancer Center. Dr. Malmstrom held a professorship at both Cornell and Robert Wood Johnson Medical School before she moved to California. She is certified in robotic surgery and specializes in the treatment of cancers of liver, pancreas, melanoma, and sarcoma. Dr. Malmstrom has published over 100 scholarly articles and is funded by the National Institute of Health, NIH, and several foundation grants. She is a sought-after speaker at national and international conferences. Dr. Malmstrom is a member of the Liver Health Foundation's Medical Advisory Council. In 2023, she received Liver Health Foundation's Healthcare Visionary Award. Dr. Malmstrom, welcome back, and thank you for your participation. And our other panelist is Dr. Jaslyn Singh. Dr. Jaslyn Singh, MD, is a health science clinical instructor at the University of California, Los Angeles, which we all lovingly know as UCLA. Dr. Singh graduated from Washington University in St. Louis, after which she dedicated 1 year to City Year, which is an AmeriCorps program focused on tutoring and mentoring high school students in schools with low graduation rates. She graduated from the Ohio State University College of Medicine and completed her internal medicine residency and gastroenterology fellowship at Loyola University Medical Center. She finished her training in transplant hepatology at the University of Southern California, or USC. Dr. Singh has been involved in clinical research into alcohol-related liver disease and hepatocellular carcinoma. She treats a spectrum of liver disease and cares for patients after liver transplantation. She is board certified in internal medicine and gastroenterology. Dr. Singh is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Singh, welcome to Liver Cancer webinar. We are so happy to have you with us tonight.
Thank you for the invitation, Farah.
Oh, you're very welcome. Thank you. I know all of you are very busy, and we really appreciate that you volunteer your time and do this so our patient can have a good understanding of liver and liver disease. So over the past few days, I had received some questions from audience who are here or some that couldn't be here. And I have submitted that to our presenters to review and respond. However, everyone is welcome to post your question on Q&A and chat tabs, and we try to catch them all. Dr. Ahern, would you please start the roundtable discussion?
Jasleen, is there one of these you want to take on?
Yes, Farah, are you going to read the questions, or should we just go down the email?
Yeah, I sent you the email because I didn't know which one is more important and more meaty for you to get into the details for the patient. But I have a question. Maybe either of you can respond. The actual, you said external beam radiology what does that mean? What is that electricity that comes through the body when they are doing this external beam? And it's that only for cancers that are localized or maybe the first stages, or what is that? I'm very confused about that.
Yeah, I can take that question. But essentially, so for liver cancer, most of the radiation actually that we do is sort of internal, mostly through Y90. So we're directly delivering, radiation, radioembolization essentially to the tumor. So actually, this external beam radiation or stereotactic body radiation therapy is not used as much in liver cancer as much as it is in other cancers such as breast cancer. But essentially the radiation comes from outside of the body. It's coordinated by radiation oncologists and has a role in some cancers, but is not really commonly used in the treatment of liver cancer, in particular hepatocellular carcinoma. Now, radiation therapy in cholangiocarcinoma is a little bit different and does play more of a role. But for the majority of liver cancers, which are hepatocellular carcinoma, there is a limited role.
Side effects?
Side effects of radiation, I mean, essentially, since, people can feel fatigued, they can have some discomfort there. Sometimes with radiation on the inside, it can cause some scar tissue as well. So these are things to just, pay attention to.
Well, the way radiation therapy works is radiation is bad for all of the cells in your body and would kill all the cells in your body if you give them too much. But the way it works is they cross the beams so that only the area that they're really targeting gets enough beams that it becomes toxic. So the goal is to sort of kill it's pretty amazing what they can do with computers to target that little site. But everything nearby gets some degree of harmful radiation. And so anything that's nearby can be injured with it. And your whole body gets radiated as well. So it, like Jasleen said, it can make you feel sick.
Okay, thank you very much. Now we can go to the questions that I had sent you.
Okay, so I think the first question was What can be done if steatosis begins in the transplanted liver? Can medicine be used and cure it? That is a great question. That is something that we are seeing quite commonly, especially because fatty liver disease is the second leading indication for liver transplants. So we know that, even though someone is transplanted for it, if they have risk factors for developing scar tissue in the liver, and fat, it can happen again. So what we do is keep a close eye and make sure that things such as diabetes, high blood pressure, high cholesterol are treated appropriately after. Unfortunately, there are no medications that are currently FDA approved for the treatment of fatty liver. There may be one that's coming out in a month. But again, we're still awaiting FDA approval for it. So mostly it's just lifestyle changes and of course, no alcohol, since alcohol can also contribute to fat in the liver.
I just want to jump in because, Laurie, I see Dr. Maelstrom, but she is in part of audience and not a part of our panel. Is there something you can do, or do you want me to go back and send her the link?
Yes, I just added her as a panelist.
Okay, very good. Thank you. Okay, please continue. Dr. Maelstrom, welcome. I don't see you yet, but you have been added as panelist, so we should be seeing you shortly. Okay.
Larry,
I think the second question, I would like to hear about the recent updates on HCC management. Dr. Ahern or Dr. Maelstrom, I don't know if one of you want to take that, or happy to discuss as well.
Sure. Hear me? I'm trying to see if my
we can hear you.
video. Wow. Do you all hear me?
Yes.
Okay, great. So for us, the first, we're in a cancer center. We don't have transplantation. So the first question we ask when we see a patient is if they're potentially a transplant candidate. And if they are, we send them to our friends at USC or Loma Linda or UCLA. And if that's not the case and ablation is not an option and radioembolization or chemoembolization or bland embolization is not an option, more and more we're treating patients with immunotherapy, and there are more and more immunotherapy trials. And I think the biggest question that remains is a consolidation or a combination of these therapies a foreseeable future for us, such that we can get patients to surgery or to transplantation. I think that is the biggest unknown right now, and probably the biggest area of study right now is transplantation post immunotherapy. I'd love to hear Dr. Ahern's experience with that right now, because that is a big topic of discussion and conversation in the field as I see it with my transplant colleagues.
Yeah, the immunotherapies have really generated some amazing responses in patients and have shrunk down tumors that previously would say are well outside your criteria for transplant. There's one specific challenge with those therapies in transplant, and that is because they stimulate the immune system, they also stimulate rejection of the liver. And so you cannot use those therapies post-transplant because they cause very, very profound rejection of the liver, and will basically cause the patient to lose the liver transplant. So with patients who respond really well to this therapy, and it looks like they now may be a transplant candidate, we do try to get them to transplant. But you have to let the medicine wash out of the system so that at the time of transplant, it won't be around and the body won't reject the liver. And the challenge of it is that means you have to usually give about a 6 to 8 week period off of immunotherapy. And the cancer is now not getting the treatment that it responded so well to. And so it's a little bit of a gamble to see if that cancer will rebound and grow in that interval. If it stays contained, then we will get you on the transplant list and try to get you transplanted. But we have to have that, what we call the washout period, where we let that medication wash out of the body so we can safely do the transplant. I can name about 5 patients that we've successfully downstage, meaning we took too much cancer and got it down to the appropriate size cancer using a combination of immunotherapy and local regional treatments that we were able to successfully get the transplant. So I guess we'll keep going down the list.
Yes, please.
So Jazzy, you want to take the role of hepatitis in developing cancer?
Yes, role of hepatitis. So basically any kind of inflammation can predispose somebody to developing cancer. The ongoing inflammation, reproduction of the cells can lead to mistakes in that process of making cells, which can lead to cancer. And so patients with, chronic hepatitis B do have sort of this chronic inflammatory state that predisposes them to liver cancer. And in addition to that, with a virus such as hepatitis B, by integrating itself into the host DNA as well, causing changes that can, that predisposes people to liver cancer with chronic hepatitis B.
I know that I know the answer to what the next one is about gender differences between male and female. And as I mentioned, I know males are more likely to get HCC than females, but I have no idea why. Do you guys have a good answer for that?
I'm not sure how strong the data, there are data to suggest that maybe estrogen is protective, which I think is it may be the next question, against developing liver cancer. But what's kind of interesting about that as well is that estrogen is also known to mediate a benign liver lesion that Dr. Ahern discussed, which is a hepatic adenoma, which with certain characteristics actually can transform into a cancer. So I think that's why the data are more controversial than straightforward, but perhaps estrogen is protective.
Dr. Maelstrom, what's your experience in that? Oh, maybe we lost Dr. Maelstrom. Okay. And that also goes not only for male and female, but also from your background, your genetics, your history of the country that where you're from. Is that right? You see that a lot more in Asians than the whites, Middle Eastern. What do you have read or know?
Go ahead, Jesley.
Oh, yeah, I was just going to say, I mean, I think the only reason that there's so much liver cancer in patients of Asian descent or African descent is because of the chronic hepatitis B. So I'm not entirely sure that it's necessarily just genetics there, because an environmental factor plays a role. So the virus is endemic in those areas.
Yeah, so we really don't have any way to suss it out because that chronic endemic hepatitis B has been present in Africa and Asia as long as we've been studying people. So whether it's genetics or it's because of the environment, you can't really sort it out. Did we get Dr. Maelstrom back?
I'm back. I'm sorry. I'm in a new doctor's lounge and they don't have Zoom on the thing. So I have audio, but I don't have video. So I'm very sorry.
Well, we'll hear you. That's fine.
Do you want to take on what's this T-cell therapy stuff we hear about? That was the question, second to last question on the list.
Yeah, it's an exciting time for T-cell therapy. Essentially, there's two different kind of conceptual thoughts are that you take T-cells from patients and you amplify the cells that have T-cell receptors that are targeting the neoantigens that are specific to the patient's cancer itself. And then you amplify them, you grow them in vitro, and then you feed them back to the patient. The issue is that we have not seen great responses for T-cell therapy for solid tumors. Historically, the specific tumor that we've seen it in most significantly has been melanoma, but even that is still very much in evolution. I think the fact that HCC has demonstrated response to immunotherapy renders it as a potential target for the future. But today in 2024, there are trials, but in terms of it being an established therapy for hepatocellular cancer, stay tuned. We're not there yet, but stay tuned.
One of the questions that I had received from many of people was that will there be a day that we can say we have cured liver cancer for sure? And is it possible that with AI, that scientists can develop a 3D liver that works just miracle like our liver and transplant with that because we have such a shortage of a donated liver?
This one's actually one of my favorite questions. So in terms of cancer becoming completely curable, I think the way things have progressed over time is that every time we discover a great treatment for cancer, it works, and then we discover the next cancer. And there are lots of cancers that were previously untreatable that are now really responsive to therapy. But the human body is so complex that we keep discovering new ways for us to run into trouble. And, you know, that is sort of what I would expect in terms of the natural history, is that we will continue to make these incredible advances, and some of the things that currently are considered untreatable will become treatable. But we always find new challenges because we're all human and flawed. In terms of the building the liver, it's a kind of a really interesting study in how what science can and cannot do. We have become really, really good at manipulating cells and getting cells to grow, but we have not become really good at is figuring out how to get the cells to talk to each other and do all the things that they do in our body working together. So people have invented kind of an equivalent of liver dialysis, where they have liver cells and they can run your blood through the liver cells. And those liver cells can make all of the things that your liver would make. So they could replace your liver function. But they don't have things like bile ducts, and they don't treat scarring in the liver. And so it's not really a cure for cirrhosis because it can't replace a whole liver. The more complicated the organ and the more parts have to work together, the harder it is for us to mimic it and build it. We've built with AI things like tracheas, which are a simple tube and can replace your trachea with a 3D printed trachea. But we haven't figured out ways to mimic things like kidneys or livers, where multiple cells have to work together and do things. The closest anyone has come so far is a therapy, is a experimental treatment where they took organs, and then they used detergent to wash all the cells out of the organ and left the framework of the organ. So they could make a framework of a heart, or a framework of a liver, or a framework of a kidney. And then they could use different people's cells to put back into those, or different mice cells really, to put back into those frameworks. And those cells will, that's the closest anyone's come to getting the cells to line up the way they're supposed to. Doing that, they've built a heart that can kind of beat at about 20% of a normal heart capacity, and have gotten some degree of lung function. But we still haven't really figured out a way to mimic the complex structure that makes a liver or a kidney.
Mind blown at what's happening in science. We are working with quite few patients who have childhood liver diseases like BA, and we have a young woman who was completely normal until she was 11 years old, and all of a sudden she developed autoimmune hepatitis. How does this thing happen? All of a sudden the cells in the body go crazy? Is that what happens? She was okay before, and she was very active, very physical.
Yes, for childhood diseases, you know, there's certainly it's more of a genetic component that leads to either having some kind of chronic liver disease, or even I saw a question about liver cancer in children. And so unfortunately, it's just bad genetics that leads to that sort of risk or predisposition to developing cancer or other liver-related complications.
Dr. Mellstrom, are you with us? What are your experiences in dealing with childhood liver diseases?
Well, I'm hepatobiliary surgeon taking care of adult cancer, so I don't necessarily see those. The thing that we most often see are patients that develop subsequent strictures if they've had a history of autoimmune hepatitis. And those we manage as best as we can, non-invasively, but at times we do have to intervene and do bypass procedures. That would be my experience. It's more on the surgical side as an adult rather than as a child.
Right.
So for your 12-year-old who got autoimmune, unfortunately, autoimmune hepatitis is something that can happen almost at any time, but it's more prevalent in young people and more prevalent in women. And it's something about the regulation of the immune system causes them to start recognizing your own cells and attack the liver. And you know that there's something about puberty that tends to stimulate that. And you know, young people have much more robust immune systems, so it tends to be younger people that suffer from these bad autoimmune diseases, and it makes them one of the most difficult group of patients to treat because they're actually much healthier. They don't meet the same criteria as people who are really sick and from cirrhosis. And so they have to get really, really sick in order to get liver transplanted. And that's one of the reasons why we tend to target these patients if they have a living donor available. It's a great cure for them. But it's one of these things, no one really understands what the guardrails on the immune system that fall off are. But once they do, it can be very difficult to stop the immune system from destroying the liver.
Yeah, and in, go ahead.
I was going to say, now that more and more patients are getting immunotherapy, we're seeing more immune-mediated hepatitis, and that's mediated by that's treated with steroids, but we're going to see more and more of that as time goes.
That's us intentionally breaking one of the guardrails. You know, that the guardrails, those things that mediate.
Iatrogen.
Right. We take those guardrails away so your immune system will go after the cancer, and sometimes those cells go after you too.
And in the studies I was reading, it was saying in the past it was mostly older people who developed liver cancer and had hepatitis, then liver cancer. But now they're seeing it more and more younger people who are developing liver cancer without having hepatitis. Why is that? Our lifestyle?
I think a big part of that is actually fatty liver. So, it's we're seeing a lot more liver cancer actually in people that just have fatty liver. They may not have cirrhosis even. So there is probably a, big role of lifestyle, diet, and all of that plays a role in that.
Did you guys see the New England Journal paper that just came out with the medication to mitigate NASH cirrhosis? Did you guys just see that? It just came out like last week.
Yes, that's resmetirom. Yes, that's the medication that's we're going to find out if it's approved by the FDA next month, March 14th.
And how are you going to pick your patients to give it to?
Great question.
I have fatty liver on my scan. Is there anything I can do? And I say, nope, just eat well.
Yeah, I think it's going to be limited probably to people that do have some degree of fibrosis. So the patients that were in the studies were mostly stage 2 or stage 3 fibrosis. So I think those are going to be the patients that insurance will authorize as receiving treatment, are the stage 2 and 3. So not cirrhosis.
Cool. Thank you.
Well, that's all the time we had, but I want to thank Dr. Ahern for your excellent presentation and roundtable discussion. We hope to continue working with you in 2024 and have you more in our webinars and also our live events. Thank you, Dr. Malmstrom. I know that you have been very busy, and I really appreciate you took time and joined us. I'm sorry we didn't have the video, but we heard you, so that was great. Thank you. Thank you, Dr. Singh. We truly appreciate your support and collaboration with us. You have been a great support for us anytime I reach out. Thank you for that. So Liver Health Foundation will host a webinar on hepatorenal syndrome, or HRS, a rare disease which impacts kidneys and liver and may cause ascites, hypertension, cirrhosis, and more. The webinar will be on Zoom on February 29th from 5:30 to 6:30. It just so happened that February 29th is a rare disease day, so we want to make sure that we bring that home. The speakers at HRS webinar are Dr. Alexander Koo, Professor, Medical Director, Liver Transplantation at Cedars-Sinai, and Dr. Arpan Patel, Assistant Clinical Professor, David Geffen School of Medicine, UCLA, and a staff hepatologist, West Los Angeles VA Medical Center. Liver Health Foundation is on all social media. Please visit us. We do announce our events, programs, and give you option to register through social media to attend our events. Thank you again to our panelists. We really appreciate it. It was a wonderful presentation and great discussion. Thank you. Thank you to audience for joining us. Remember that we record these webinars and we release them on our YouTube channel. So that helps those people who couldn't be today. And finally, happy belated Valentine's Day to all. Stay safe and healthy, and we will see you on February 29. Thank you and good night.
Thank you, Farah. It was great.
Thank you so much.